Good morning, everyone. Can you hear me okay? Great. I'm thrilled to be here as a hospice person and a nurse with APT Associates out of the Cambridge office. Right now I'm doing U.S. health policy, but my background is community health, oncology, but most of all, hospice. I hate to give away my age, but I'm older than the hospice Medicare benefit. And I remember the days that we were doing hospice with the home care benefit, kind of with a group of volunteers, and we did not have liquid morphine, we didn't have liquid Ativan, we had no suppositories that you could give for pain medication. And I remember driving to the emergency room to get a little syringe of morphine so I could drive back to my patient and give it to her because the family did not want her to go to the hospital and she was in so much pain. So we worked really hard to keep those patients home without the benefit of having this wonderful hospice Medicare benefit that we have now. We couldn't get hospital beds unless the patient we could guarantee they couldn't sit up, less than 45 degrees. We could not get oxygen unless we did a set of ABGs. So I don't think for those of you who are a lot younger than I am, you have no idea what it was like trying to keep these people home. So it's a wonderful benefit, and it's up to all of us to protect it and to make sure we keep the standards high with high-quality hospice. But I want to spend a few minutes just telling you a little story, one of my favorite hospice stories. We had a patient a few years ago. I was a hospice director on the south side of Massachusetts, and we had a patient that was referred to us on a Thursday afternoon with ovarian cancer. And it was kind of those last minute, get here today. She's coming home from the emergency room. Patient had gone in for chemotherapy, her regular Thursday chemo, and she was obstructed. And the daughters were on their way into the ER. So I sent the liaison in, and she's calling me from the hospital and said, we got to get her home. She wants to come home. She's not going to be able to get her chemo. So they put her on some IV fluids. We brought her home. Her husband wouldn't talk to anybody. He was so angry at her and at the whole family because she was giving up. She wanted to go home on hospice. So we got in there that Thursday afternoon. We did give her some IV fluids over the weekend. And our social worker was able to go out on Friday and do her assessment. And one of the conversations she had with the patient was, what was she going to miss the most? And what she was going to miss the most was the fact that her two daughters were both engaged, and one was going to be married in a year and a half, and the other was going to be married the next year. And they were in their late 20s. And so they shared that with the family, that's what she was going to miss, and she was going to miss their weddings. By Monday, after we had seen her over the weekend, she was feeling better. And the fluids were working, and she was actually passing things, and she was able to have some clear liquids. And her husband had convinced her that she could still get this chemo, which the doctor was not opposed to. So she let us know that she was going to come off of hospice. So by Thursday, she went back for her chemo. We had to revoke her, and she stayed off of hospice for a few weeks. So one of the staff people in my office who worked in another side of the building came over to thank me and said, I can't thank you enough. You have such a great team. And I said, why? What are you thanking me for? She said, because what you have done for this family. She said, she showed me a picture. The two daughters had gone out and bought their wedding dresses. And so the next 2 weekends, consecutively, they planned their weddings, and they both got married. And about a month later, we got a call, and she was ready to come back to hospice. But the difference this time was that her husband was on the phone, and he was ready, and he said, I'm ready for her to come to hospice. We need her to come home. She had ended up back in the hospital with another obstruction. And she came home, and on her way home, she requested going by Castle Island for one last time. She wanted to get a lobster roll, and they drove her home. And then we had her for, I think, about 8 more weeks before she died. But everyone that went in there, she shared the pictures. She could not say enough about the 2 weddings that she got to be part of. And I remember talking to the nurse like her last week, because we all got attached to this whole story. and saying, how's she doing? And she said, I went in there yesterday, and she said, I am so happy. I'm happy, my family's happy, and I got to go to those weddings, and that was the most important thing. So I just tell you the story because I think it points out how much you guys do for patients. And it's not just about the patient. Certainly we kept her comfortable, we kept her out of pain, but we kept her home. And what we did for that whole family, in that, they had a better outcome, and I'm sure did really well afterwards, knowing that they were able to have her partake in the weddings. And what a gift to her daughters for her to be there. So I think it just points out that, high-quality hospice is what it's all about, and that's what today is about. So I'm happy to talk to you about the HIS and kind of what that's about. And as Stacy said, we're hoping this whole day that you can use this as a training for your staff, for new staff and older staff. So we are going to go over some of the things that are happening right now with the quality, and then we'll move into the new measures later. But you can use these when they're posted online to educate people that come into your organization. So I'm going to, I got to use the clicker here. There we go. Okay, so today I'm going to discuss the HIS item set. Some people call it the HIS, the reporting requirements. I'm describe the assessment types that comprise that. We'll talk about the thresholds for compliance in the fiscal year 2017 and 18. I'm going to summarize the effect of non-compliance on the annual payment update. And then we'll talk a little bit about some circumstances where you may get an extension or an exemption if that's necessary. So first of all, the hospice item set, what is it? It's basically a standardized set of items that we're collecting once the patient's been admitted, and then this is going to send information on that'll give us an idea of what's going on across the whole country. So it's to capture patient-level data on every patient admission. And these items, some of these items can be used to calculate 7 quality measures that have been approved by the National Quality Forum. They've endorsed them. And they did endorse quite a few measures, I think about 3 or 4 years ago, for hospice and palliative care. And it really is all about, providing high-quality, patient-centered care and alleviating suffering. And those are the measures that are part of this whole quality program. The data collection started for HIS in July 2014. I remember it vividly. It was a very interesting time for all of us hospices who are not used to submitting this kind of data. So I think, we're in the big leagues now, guys. We've moved into the home care world. I think for a long time people didn't really pay attention to what we were doing. But it isn't a bad thing for us to all be having to hold up to some high standards for quality. So the HIS data collection consists of selecting responses to the items in conjunction with your assessment. And it can be done during the assessment. I know for those of you that are on electronic medical record, some of that information can go right into the system, but it also can be done via abstraction after the fact. And any part of your team can help do that, whether it's a nurse, a volunteer, an aide. They can help collect this data for the HIS form. So this table just shows you the quality measures that we currently have, and then the bottom, there are 2 of the new ones that we'll be talking about later this morning. And the National Quality Forum number is on the left-hand side. So the treatment preferences, and that includes preferences regarding CPR, hospitalization, and as I mentioned about my case that I talked about, IV fluids, things like that, other things that they want to have preferences regard. And that's something I'm sure you all do, but it's a matter of just making sure that we're doing this 100% of the time. Beliefs and values, and that's the spiritual component, really trying to find out what's important to this family and what makes sense for this family. And certainly if the patient prefers not to discuss that, that's fine, but it's up to us to open the door for that conversation. And then there's pain screening, which I'm sure your staff does on admission, but if they screen positive for pain, to lead into pain assessment and do a comprehensive pain assessment. And then there's dyspnea screening, and if there's an issue with shortness of breath, what are we doing for that? So to coincide that with a good treatment plan for dyspnea. And the last one that we've been currently collecting is the patients who are treated with an opioid who are given a bowel regime. That's one of my big pet peeves on a Friday, having people go out running around trying to give enemas and things. So, especially your new nurses, to make sure that they don't forget about those bowel regimes on those patients who are receiving, even if it's a PRN opioid, because, it very quickly can turn into a scheduled opioid on a weekend. So everyone should have a bowel regime. And then the last two on the list here are the new measures, which we'll be talking about later today. The first one is the Hospice and Palliative Care Composite Measure. And that composite measure is really going to be pulling together the 7 that we just discussed. It's the 7 you're already collecting. And lastly, the last one is the hospice visits. So those are looking back at the visits in the last week and the last 3 days of life, and really kind of counting the kinds of clinical visits that were made, whether it be an aide, a volunteer, a nurse, social worker. And that'll be another new measure that we'll talk about. So another way to look at this data is to kind of go through the sections for the HIS that we have. So we have the administrative information. The middle column just says whether it's a care process or not, and then the corresponding quality measure. So in section A is mostly administrative information. This is information that you're going to gather from your intake process, but it's also information at the patient level, what's the patient's name, Medicare number, whatever. It's not a care process, it's really just data collection so that we can compare and see who are these patients that you're following and where are they coming from. Preferences, we already talked about that, but section F includes not only the treatment preferences, but also the beliefs, values, and the spiritual question. Then there's active diagnoses in section I, and that's just choosing, I think it's cancer diagnosis, dementia, or non-cancer, not a care process. Section J is the health conditions, and those include the questions about pain screening, pain assessment, dyspnea screening, dyspnea assessment, and those are all part of the quality measures, and that's kind of looking at that whole care process and how we're managing patients when we first take them on. Section N, medications, and the only question in there really has to do with the opioids, whether it's an ongoing opioid or PRN, and then whether they were given a bowel regime, and that's a care process. Section O will be discussed later this morning. That's going to be brand new, and that's going to be in the discharge HIS. We'll have to do at the hospice visits. And this will be the first section that's going to look back, because all of the measures we're currently collecting are just on admission. So your first couple of days, your first week. So this will be a nice way to look back and say, what care did we provide that last week? And section Z is the record administration. It's really verifying the information that's being put into the system. It's just the signature of the person. So here are the two data sets. So there's the admission data set, and that includes, A, F, I, J, N, and Z. There are over 50, I think there are a little over 50 individual items that are part of the HIS we're currently collecting. And the HIS discharge right now has been almost duplicative to the admission HIS in terms of the administrative questions. The only two new things have been the discharge reason and the discharge date. So what's required? Basically, regular and ongoing submission of the HIS data. So since we started doing this in July, you've just been expected to make sure that you're putting it in for every admission and every discharge. Data collected is submitted on all patients, regardless of the age, regardless of the payer, or where they received their services. So every hospice that is Medicare certified needs to be submitting data on admission and discharge. And these records are submitted to CMS through the KEYS ASAP system. Quality Improvement and Evaluation System, Assessment, Submission, and Processing. That's a mouthful. But the HIS admission record must be submitted before the discharge. You've probably found that out when you try to submit an admission and discharge at the same time. Sometimes it'll kick it out, it'll give you an error, especially those short length of stay patients that might die within the same day. So in terms of the submission requirements, of course, all of you are following the COPs, and you have your nursing doing the assessments, their initial assessments in the first 48 hours, and then the first 5 days to do their comprehensive assessment. So the first set of guidelines is really a guideline only to recommend completing these HISs within 14 days after admission, and then within 7 days after discharge. The actual deadline is 30 days. So you have plenty of time, if you do it within the first 2 weeks, that if you found an error, that you have plenty of time to correct that. And that's what the guideline is for. But the real deadline is 30 days after admission and 30 days after discharge. Or another way to think about it is the admission date plus 30. And that would be the last day you can submit your information. So here's a polling question for you. Everybody has a clicker on the table, you guys? Mr. Smith was admitted to hospice on November 11th. An HIS admission record for Mr. Smith was completed on November 15th. What is the latest day that Mr. Smith's HIS record can be submitted? A, November 25th, B, November 29th, C, December 11th, D, December 15th. Everybody got an answer in? Okay. Oh, 88% said C. And that is correct. So C would be the answer. So since there are 30 days in November, and I know that from grade school, you would take that admission date plus 30, and that would be the last day you could submit. Okay, so what about providers that fail to submit? Basically, they are going to be subject to a reduction in the annual payment update by 2%. So certainly it behooves you to make sure that you're submitting the data. So the reporting cycle spans over a 3-year time frame. For example, in 2019, the reporting year will consist of the data that we're collecting this year. So from January of 2017 to December of 2017. During 2018, it'll be determined whether your program was compliant or not. And if you met the requirements, then you will see your update in 2019, or a reduction if you did not. So you would be reduced in 2019 if you fail to submit based on the thresholds that are set. So here's a table just looking, and Stacy had also talked about this. In terms of the reporting year 2018, so all the information from last year, you would need to have met 70% threshold in order to get your annual payment update in 2018. So in 2019, it'll be this coming year, and the submission threshold is going up to 80%. And in 2020 and beyond, it's going to go up to 90%. So for this past year, as long as you've met 70% where you've accurately submitted the data on time, then you should be fine. So how is this calculated? Basically, the percent of HIS records that were submitted on time is the numerator, divided by the denominator, and then multiplied by 100 and rounded to the nearest whole. And I'm just going to show you the calculation for that. So the numerator is the records in the denominator that were successfully submitted within the 30-day submission deadline. And the denominator are all the records that you submitted for your admission and discharge during that time frame. So let's look at an example. Hospice Agency A cared for 150 patients during calendar year 2016. Of the 300 admission and discharge records that were submitted, 250 were submitted on time. So 250 would be our numerator, 300 the denominator. So our compliance rate would be 250 over 300 times 100, or 83%. Everybody get that? So here's another polling question for you. Hospice Agency B cared for 200 patients during calendar year 2016. It submitted HIS records for all the patients, but only 190 admission records and 180 discharge records were on time. So what is the denominator? So they cared for 200 patients. They submitted 190 admission and 180 records on time. So what is the denominator? A 400, B 200, C 370. So you have your clickers, right? D 190. Everybody take a stab at an answer? Yep. So 55% said 370, but 36% said A, 400. 400 is the answer. So the denominator, because they did 200 admissions, they had 200 admissions and 200 discharges, so there's your 400, that's your bottom number. The 370 would be the numerator. So those are the ones they submitted on time, but they're going to be divided by the full set of admissions and discharges. And that's how your threshold is going to be calculated. So let's just talk a little bit about extensions and exemptions. Hospices can request an extension or exemption from data reporting in the event of an extraordinary circumstance. Requests will not be granted for vendor failures or fatal errors or a staff error like the wrong birth date. So again, that's why you need to submit early and follow your reports and make sure that you're getting them in accurately or resubmit before the 30-day deadline. Requests might be submitted in writing via email to the quality mailbox and within the 30 days. So within 30 days, you can request an extension or an exemption. So some of the reasons you might have an extraordinary circumstance could be a natural disaster, preventing some timely submission of quality data, could be a disaster that's widespread or affected multiple structures, or it could be just isolated to your location, could be a fire or something like that. Extensions can be requested. CMS can extend the submission deadlines for specified deadlines for 30 to 45 days beyond the due date. And an exemption would be something where the deadline would be waived. So if the deadline was waived, they can give you an exemption, and then it would not affect your annual payment update. So what about new providers? So brand new providers that receive their CMS certification number after November 1st of any calendar year are excluded from a payment penalty for the reporting relevant fiscal year. For an example, a hospice provider received its CCN notification letter on November 2nd, 2017. Therefore, they would not be required to submit HIS data for that year. They'd be excluded from any payment penalty that would affect them in the 2019 annual payment year. But they would have to submit submissions based as of January 2018. So again, after November 1st in a calendar year, if you're a brand-new hospice, you kind of get a waiver those first couple months, but as of the following January, you need to start submitting your HAS data. So here's some information on the quality reporting webpage. This is a great link. There's lots of good information there, so I would encourage you to take a look at that. And in terms of the hospices, if you have questions or you need an extension, here is the email address to go to. Any specific questions of the information I just gave you? Okay, thank you very much. Enjoy the day.